In 2021, the General Medical Council made a commitment to eliminate inequality in medical education by 2031. With just 5 years to go, their latest report confirms that at a national level, a significant attainment gap remains across all the index measures and at levels that call for continued system-wide action. Regarding their education and training target, only limited progress has been made, and it is worth mentioning that the GMC formally began working on differential attainment in 2013. I would argue that the reason for this limited progress is that we continue to view differential attainment through the limited lens of the deficit model. Before I go further into the presentation, I'd like to share my intention. And this is a great quote by Brené Brown: "I'm here to get it right, not to be right." This quote reminds me that just showing up and being willing to try is in itself valuable. And in order to get it right, there needs to be permission and safety to be challenged with care and support. In our attempts to get it right, genuine mistakes will be made, and that is okay because it will be followed up with accountability. It's also important not to confuse safety with comfort. So discomfort is part of growth. Safety means freedom from harm, not from challenge. Throughout the presentation, I invite you to reflect not only on what you think, but also how you feel. And if at any point you notice any tightness or constriction in your body, taking a few moments and breathing deeply will help to bring a sense of ease. The deficit model within the context of education is where the student characteristics are the main factor for explaining differences in attainment. Things like lack of skills, knowledge, or experience, rather than focusing on the structures and the discrimination that exists. Therefore, ownership, accountability, and responsibility for these inequalities do not reside with the institution, but rather with the individual. This is a slide from a presentation titled "Narrowing the Gap of Differential Attainment," which was presented to a group of educators in the Northwest. Although a need to move away from a deficit model was highlighted, because there's a lack of an effective alternative model, we continue to go back to focus on individual learners. Part of the presentation included generating this word cloud. So they invited the attendees to share what words come to mind when they think of differential attainment. There was 31 educators and each one could contribute a maximum of 3 words. As you can see from the word cloud, inequality was the most frequent word. However, I want to draw your attention to some of the other words: different capabilities, deficient, inadequate, slower, underperformance, struggling, failing, individuality, knowledge base, language, and sickness. All of this suggests that amongst educators, a deficit narrative is still prevalent. It's also important to explore the language we use to define and talk about differential attainment. This is the definition that was mentioned in the presentation, and I want to draw your attention to these terms: unexplained variation, groups of individuals, protected characteristics. There's emphasis on that it's not easy to address. And there's a statement: we cannot rule out discrimination and bias. If we look at how the GMC defines differential attainment, they use words such as gap. They mention that differential attainment can be an indicator that training and medical education may not be fair. They also mention that differentials that exist because of ability are expected and appropriate, whereas differentials connected solely to age, gender, or ethnicity of a particular group are unfair. The reason why it's important to explore these words and terms in more detail is because words actively shape perception, action, and therefore outcomes. So for each of these terms, I'll share the likely interpretation and response and the potential outcome from this. The word unexplained suggests that causes are unknown. There's nothing specific to act on. This reduces motivation to intervene as we wait for more clarity, and the system outcome is inaction. There's a default back to deficit narrative. Use of the word variation or gap suggests that it's incidental and there's no clear pattern, which normalizes the gap and reduces the sense of urgency. This leads to patterned inequity being minimized. When we say groups of individuals, so the focus again is either on groups or individuals, and the question that immediately comes to mind is, what is it about this group that explains the difference? This again reinforces the deficit narrative. When we emphasize that it's not easy to address, this gives the impression that it's too complex or intractable, leading to avoidance and disengagement from addressing differential attainment, and the status quo is maintained. Stating that we cannot rule out discrimination or bias suggests bias is only one possibility and may not actually apply here. Therefore, bias and discrimination are not actively interrogated and it remains unchallenged. The GMC mentions that it can be an indicator, so it may reflect unfairness, but not necessarily caused by it. This leads to hesitation to act and a need for more proof, again leading to delayed or absent intervention. May not be fair suggests that unfairness is possible, but it's uncertain, reducing urgency and deprioritizing differential attainment. And inequity is therefore tolerated. Stating that differentials that exist because of ability are expected and appropriate might sound reasonable. However, remember we are talking about groups of individuals. This suggests that some groups may legitimately perform worse, leading to deficit-based assumptions about individuals and groups, and the deficit narrative is reinforced. When we say differentials connected solely to protected characteristics are unfair, it suggests that unless bias is the only cause, unfairness is unclear, making the threshold for action very high and leading to doubt about discrimination. This leads to inequity remaining unaddressed, and all in all, limited progress. All of these words and terms are examples of softening of language, and it can also be seen in the study commissioned by the GMC Fair Training Pathway for All. This was a qualitative study published in 2015. I did a simple word count looking at both the reports for part 1 and part 2, looking at how many times the words bias, discrimination, prejudice, and racism were mentioned, excluding the quotes and references. You can see here that the most frequently used word was bias, which is a focus on individuals. The least used word was racism, which is a focus at the structural and systemic level. Even when these words were used, it was potential bias, perceived racism, anxiety about discrimination. And the impact of this softening of language is that it dilutes the sense of moral urgency. It leads to a diffusion of responsibility and accountability. It deracializes racialized harm. It excludes the lived experience and the human cost of differential attainment, and it therefore limits the scope of intervention. When we use this kind of language, we must ask whose comfort and interests are being prioritized. As this study formed a core part of the GMC strategy for achieving fair training cultures, let's have a look at it in more detail. The main purpose of the study was to explore why Black, minority ethnic UK graduates and international medical graduates perform worse than white UK graduates. And it looked at the causes depending on whether they were at macro level, meso level, or micro level. Although the authors stated that a deficit model should be avoided, they used psychological theories of risk and resilience as a framework to interpret their results, and this brought the focus again back on individuals. The study identified 13 risk processes and recommended 13 protective processes. Each of these risk or protective processes were identified whether they functioned at micro, meso, or macro level, or a combination. This chart demonstrates that most of the risk processes identified were at micro and meso level. When we look at the recommendations, the protective processes, the vast majority were at micro level, and there were no recommendations at macro level. The study identified that there's a focus on international medical graduates, as it is more difficult to explain ethnic differences within UK graduates. The study also identified 3 barriers to change: concerns that talking about race could impede relationships, being open about potential and actual bias could be damaging to organizations, and that positive action to address inequalities could be fair to white UK graduates. As this was a qualitative study, I searched for a positionality statement, which is a reflective account of a researcher's identity and how these factors might influence their research, everything from the title all the way to the recommendations. This was particularly important for this study as it helps set the priority for further research and significantly shape the GMC strategy for fair training cultures. As I could not find a positionality statement for this research, I reached out directly to Dr. Catherine Woolfe, who is the lead researcher. She confirmed that the researchers on the top row are all from a white background and agreed that this could have influenced their analysis. It's also clear that gender played an important role. The purpose and the objective of this study was focusing on Black minority ethnic and international medical graduates. However, suddenly in the results and recommendations section, we find that women are identified as a separate group. This demonstrates how researchers are able to select which data is significant and should be emphasized. So this got me wondering, what if the GMC had commissioned a group of Black minority ethnic researchers who used a social justice lens? What difference would that have made? And what ripple effects would that have had over the last decade? So what alternative models exist that will allow us to widen our view of differential attainment? I propose using critical theory, trauma and polyvagal theory, systems thinking, and abolitionist theory. These theories provide us with the language and framework to talk about the elephant in the room. And by changing how we talk about differential attainment, we can cause a shift in how we think and feel about it, leading to effective action. I'd like to give you a very brief idea about what these theories could offer us in terms of understanding differential attainment. So, through the lens of critical theory, postgraduate medical education is not neutral. It systematically privileges some learners while constraining others. It helps us to ask, how do wider power structures shape which doctors are seen as competent or professional, believed, viewed with suspicion? How do our judgments reinforce those patterns, and what is required to interrupt them? Through the lens of trauma and polyvagal theory, effective learning and good clinical performance require safety, yet for many doctors the training environment is chronically threatening. We begin to ask, when we see poor insight or disengagement, are we assessing ability or a biological survival response to an unsafe environment? How might our own automatic reactions and emotions towards different doctors be shaping our judgment? Through the lens of systems thinking, differential attainment is persistent and patterned. It reflects system structure rather than individual failure. We ask what conditions within postgraduate medical education are producing and reinforcing these outcomes. Which of our beliefs about ability, potential, and who belongs are holding the system in place? Through the lens of abolitionist theory, differential attainment is produced by the system, not despite it. How do practices of control, such as surveillance, documentation, and exclusion, shape how doctors in difficulty are defined and managed within postgraduate medical education? How do we reduce the system's capacity to produce harm? And when institutional harm occurs, what would genuine repair and accountability look and feel like? This is a diagram which shows the 6 conditions of system change, which is directly derived from systems thinking. Most of the interventions for differential attainment at the moment is working at the structural or explicit level. What is required are interventions that directly address relationship and connections, power dynamics, and mental models. And these are exactly the areas that anti-oppressive educational supervision focuses on. It's informed by Polyvagal Theory, critical theory, and Abolitionist theory. Anti-oppressive practice was originally developed within social work, and in terms of supervision has been used within counseling and psychotherapy. I have applied the same principles to educational supervision within postgraduate medical education. Anti-oppressive educational supervision is a relational, values-based approach that examines and disrupts power and inequities across supervision, training, and patient care. It is grounded in 6 values: safety and trust, and an important aspect of nurturing this is through contracting. Awareness and courage, and this is developed through reciprocal feedback. Advocacy and empowerment, and this is where power is shared between the educational supervisor and the trainee. Here are my references for the presentation, and I would love to know what you think.